So this is the classical hyaline arteriosclerosis which we see in hypertension or in diabetic patients or also in normotensive elderly patients. But this is quite severe in diabetics and hypertensive patients. So what we can appreciate over here, if you see, what is this? If you see over here, this is basically a blood vessel, as we can appreciate over here. Okay, so this is basically a blood vessel, and if you look at the thickness of the blood vessel, they are having a increased thickness. Okay, they are having a increased thickness. Okay, so basically this increased thickness you can appreciate morphologically as a excessive eosinophilic deposition or excessive eosinophilic thickness can be seen, and this is called as a hyaline change. Now remember, hyaline change, it is just a descriptive term, okay, so as to describe this particular morphological appearance, and it has occurred because of excessive amount of plasma protein deposition across the damaged endothelial cells. So a lot of plasma proteins has deposited over here. Along with that, there is an excessive amount of smooth muscle cell matrix synthesis as well. Ultimately, what has happened, that there is an excessive thickness of the blood vessel wall, as we can appreciate over here. See the thickness of the vessel wall, and because of this excessive thickness, if you look at the lumen, this is the lumen, so there is narrowing of the vessel lumen. Okay, so there is narrowing of the vessel lumen, as we can appreciate over here. So basically over here, the arteriolar wall is basically thickened, okay, which is thickened because of excessive amount of protein deposition. That is why we are saying it is hyalinized. Hyalinized means it is a morphological appearance. Any amorphous pinkish appearance is called as a hyaline change, okay, and because of that there is a marked luminal narrowing. This is called as hyaline arteriosclerosis, and it is seen in elderly patients with normotensive or hypertensive blood pressure, and it is much more pronounced and much more severe in diabetic patients and hypertensive patients. So it is the classical finding seen in these patients. Myself, Dr. JIBRAN Ahmed, presents to you Simply Pathology, and today we are back with an important lecture. Today we are going to read in details about hypertension. So what is clinically significant hypertension? So according to the latest guidelines, any systolic blood pressure more than 120 millimeters mercury or any diastolic blood pressure more than 80 millimeters mercury is regarded as a clinically significant hypertension. So hypertension, if you see, it is a multifactorial disorder due to cumulative effects of multiple genetic and environmental factors. So let us see what are the different types and what are the causes of hypertension. So essentially there are two types of hypertension. Number one, we are having essential hypertension, which is constituting 90 to 95% of all the cases, and rest is your secondary hypertension. So what is the basic difference? Essential hypertension is the type of hypertension where you do not have any identifiable cause. So an identifiable cause is not available in essential hypertension. So essentially it is idiopathic in nature, whereas secondary hypertension is having an identifiable cause. So these causes can either be renal or endocrine or cardiovascular or neurologic causes. So what are the renal causes? It can be acute glomerulonephritis, chronic renal disease, renal artery stenosis, vasculitis, polycystic kidney disease, renal producing tumor. What are the endocrine causes? Like primary aldosteronism, congenital adrenal hyperplasia, Cushing syndrome, steroids, pheochromocytoma, pregnancy induced hypertension like preeclampsia, hyperthyroidism, acromegaly. So what are the cardiovascular causes? They are polyarteritis nodosa, coarctation of aorta, increased cardiac output, okay, or increased intravascular volume, okay. And what are the neurological causes? Like they can be psychogenic causes or causes which is increasing the intracranial pressure, sleep apnea, or acute stress syndrome, for example a person undergoing surgery. So all these are actually causes of secondary hypertension, which is constituting only 5 to 10% of all the different types of hypertension. Okay. So now what are the important complications of hypertension? So hypertension can lead to atherosclerosis, it can cause cardiac hypertrophy and can eventually lead to heart failure, which is called as hypertensive heart disease. It can cause renal failure and ultimately can lead to multi-infarct dementia, aortic dissection, and can lead to cerebrovascular accidents like stroke. Now 50% of untreated hypertension patients will die due to either ischemic heart disease or congestive heart failure. Now, 1/3 of untreated hypertensive patients die because of a stroke. So, it is very important to identify hypertension in the early stages, because if left untreated, it can lead to death by ischemic heart disease or heart failure or by stroke. Now, hypertension remains, unfortunately, if you see, hypertension remains asymptomatic until very late in its course. Okay, even severely elevated pressures can be clinically silent for many years. So it is very important to get a regular checkup, okay, and to measure your blood pressure regularly. So there is one more entity that is called as malignant hypertension. So what is malignant hypertension? Approximately, you are going to see that 5% of patients suffering from hypertension will show rapidly rising blood pressure that if untreated leads to death within 1 to 2 years. So 5% of hypertensive patients, they will show rapidly rising blood pressure, and if untreated, it can lead to death in 1 to 2 years of time. There is a severe elevation of blood pressure with systolic blood pressure more than 200 millimeters mercury and diastolic blood pressure more than 120 millimeters mercury. Ultimately, the patient has renal failure, or there will be retinal hemorrhage or exudates with or without papilledema secondary to swelling of the optic nerve because of raised intracranial pressure. It can develop in previously normotensive persons, but most commonly it is superimposed on a pre-existing benign hypertension. So malignant hypertension most commonly develops in already hypertensive patients, okay, and it is basically characterized by a severe elevation of blood pressure, systolic blood pressure rising more than 200 millimeters mercury and diastolic blood pressure rising more than 120 millimeters mercury. Now let us try and understand the normal regulation of blood pressure. So normally, if you see, the blood pressure, okay, is dependent on the cardiac output and peripheral resistance. Now, cardiac output is basically based, okay, it is basically dependent on the heart. So this is one factor, and peripheral resistance is basically put forth by the blood vessels, okay. So cardiac output, if you see, it is basically a function of the stroke volume and the heart rate, okay. So basically the stroke volume is nothing but the filling pressure, which is the most important determinant that is of stroke volume is the filling pressure, which is basically the volume which is decided by the amount of sodium in the body. So it is dependent on the sodium homeostasis, the release of mineralocorticoids like aldosterone, which again is having a role in the amount of sodium in the body, and the release of atrial natriuretic peptide, which is causing natriuresis. So basically, or mainly, the stroke volume or the filling pressure is dependent on the amount of sodium in the body, because that is going to regulate the amount of body fluid, okay, and ultimately the cardiac output. The second important determinant of the cardiac output is the heart rate as well as the myocardial contractility, okay, and the myocardial contractility in turn is dependent on the alpha and beta adrenergic systems. So the first important parameter of blood pressure is rising cardiac output, which is dependent on two things. Number one is the stroke volume or the filling pressure, which is dependent on the sodium levels in the body, and second one is the heart rate, okay, as well as the myocardial contractility, okay. Now, apart from that, our blood pressure is also dependent on peripheral resistance, peripheral resistance at the level of the arterioles, okay. So peripheral resistance at the level of the arterioles are also, decisive of the, blood pressure in our body. So very importantly, anything that is going to constrict the blood vessels, they are going to raise the blood pressure, and dilators are going to bring down the blood pressure. So what are some of the factors which are, causing constriction at the level of the arteriole? So they are angiotensin 2, release of catecholamines, thromboxins, endothelin, and alpha adrenergic agonist, okay. So all these, they are causing constriction of the blood vessels, and therefore they are increasing the peripheral resistance, and therefore they will increase the blood pressure. Now the dilators at the level of the arterioles, they are going to decrease the peripheral resistance, and therefore they are going to decrease the blood pressure. So for example, the presence of prostaglandins or kinins or nitric oxide and beta adrenergic agonist, all these are going to dilate the blood vessels, and therefore they are going to reduce the peripheral resistance and therefore decrease the blood pressure. Okay, so constrictors are going to increase the blood pressure, whereas the dilators are going to bring down the blood pressure. So these are some of the very important determinants of the blood pressure. So there are two important determinants. One is the cardiac output, another one is the peripheral resistance. Cardiac output is at the level of the heart and peripheral resistance is at the level of the blood vessels. Okay. Now there are certain local factors which are also regulating the blood pressure, okay, at the level of the blood vessels. So the resistance vessels, okay, that is the arterioles, they are also exhibiting autoregulation. Now what is autoregulation? So autoregulation means that sometimes because of any reason, if the blood volume suddenly increases, so the vessels are going to constrict so as to prevent hyperperfusion of the tissues. Okay, not only that, not only autoregulation, but tissue pH and hypoxia. So these factors 1, 2 and 3, these are some of the local factors which are also affecting the peripheral resistance, and therefore they are affecting blood pressure as well. Now remember, it is the kidneys and the heart which are containing certain cells that are sensing the changes in the blood pressure or the blood volume, and therefore they release certain circulating effectors to maintain the BP. So in short, the heart and the kidneys are playing a major role in regulation of blood pressure. How? Let us understand that. Now if you look at the kidneys are regulating the sodium reabsorption by the epithelial sodium channels at the level of the distal convoluted tubules, or at the level of the distal tubules, okay, which is tightly regulated by the RAS system. The RAS system stands for the renin angiotensin aldosterone system. So kidneys regulate sodium reabsorption with the help of epithelial sodium channels in the distal tubules, which is tightly regulated by the renin angiotensin aldosterone system. So remember one thing, that whenever there is a fall in the blood pressure, okay, which is sensed by the fall in the BP in the afferent arteriole, or whenever there is an increased amount of release of catecholamines, or there is a decreased amount of sodium in the distal convoluted tubules secondary to decreased GFR, as in conditions of reduced cardiac output, in any of these three conditions, either there is a fall in the blood pressure in the afferent arteriole, or there is an increased amount of catecholamines that is released, that is causing vasoconstriction, or there is a decreased amount of sodium ions sensed in the distal convoluted tubule secondary to decreased GFR, as in conditions of reduced cardiac output. In either of these conditions, okay, there will be a release of renin by the renal juxtaglomerular cells. Okay, this renin, which is released by the kidney in response to fall in the blood pressure, is going to convert plasma angiotensinogen, which is basically released by the liver. They will convert angiotensinogen into angiotensin 1, which in turn will be converted by means of an enzyme called as angiotensin converting enzyme, which is released by any vascular endothelium, especially at the level of the lung, into angiotensin 2. And it is this angiotensin 2 which is going to act for increasing the blood pressure. How they are going to increase the blood pressure? They can directly cause increased vascular contraction, number one, so they can cause vasoconstriction. Number two, they can stimulate the release of aldosterone by the adrenals, which can increase the blood pressure by increasing the sodium reabsorption at the distal convoluted tubules, and therefore they will increase the blood volume. So this is how they can increase the blood pressure. So if the blood volume is more, so the cardiac output will be more, and if we know that the cardiac output is one of the major determinants of blood pressure. And thirdly, they can also directly cause tubular sodium resorption. So very importantly, the angiotensin 2, they are increasing the blood pressure by increasing the vascular contraction, or they cause vasoconstriction, and secondarily they are increasing sodium reabsorption either directly or indirectly via the release of aldosterone. So this is how, whenever the blood pressure is falling, the kidneys are regulating the blood pressure. Okay. Now, what are the other factors which are increasing the blood pressure? Okay, so very important thing is, the other factors increasing blood pressure is increased volume, okay, and increased resistance. So other factors which are increasing the blood volume is increased in the blood volume. So that can be increased, or blood volume can be increased by increased dietary intake, very important. Secondly, by inadequate excretion, as in conditions of renal failure, hyperaldosteronism, or increased sodium reabsorption, as in genetic conditions like Gentleman syndrome, Bartter syndrome, Liddle syndrome. Okay, so other factors which are causing raise in the blood pressure. What are the factors which are causing raise in blood pressure? So we know that blood pressure is it is determined by the cardiac output and by the peripheral resistance. Okay, so anything which is increasing the cardiac output, like excessive intake of salts and therefore excessive dietary sodium, or inadequate excretion of the sodium because of conditions of renal failure, or hyperaldosteronism, or because of increased sodium reabsorption in certain genetic conditions like Gitelman syndrome, Bartter syndrome, Liddle syndrome. Okay, so all of them are going to cause excessive amount of sodium in the body, which in turn is going to increase the blood volume, and therefore in turn is going to increase the cardiac output, and therefore they will increase the blood pressure. Similarly, all the conditions which are increasing the peripheral resistance. Okay, so any increase in the sympathetic tone secondary to excessive amount of catecholamines, as in the tumors of the adrenals like pheochromocytoma, they will cause excessive peripheral resistance. Also excessive stimulation of the RAS pathway, as we have already seen over here. Any condition which is stimulating the RAS pathway, again they can increase the blood pressure. Okay, so this is how we see that how the blood pressure is rising. Okay, and this is how the kidneys are regulating the blood pressure. Okay, and this is how, what are the factors which are increasing the blood pressure. So this is how it happens. Now the kidneys, the kidneys, on when the pressure is falling, the kidney is activating the RAS system so as to produce angiotensin 2, which is going to increase the blood pressure. But the kidney is also producing a variety of vascular relaxing substance, including prostaglandins and nitric oxide, to counterbalance the vasopressor effects of angiotensin. See, whenever you are accelerating a car, you also have to put on brakes so that you can come to a stop at an appropriate time. So that is why once the kidney is able to raise the blood pressure to an appropriate level, then it has to control that raise, and that is done via release of counter regulatory pressors like prostaglandins and nitric oxide. Okay, so this is how the blood pressure is regulated by the kidneys. So what is the role of the heart in regulating the blood pressure? So whenever there is a rising blood pressure, whenever the blood pressure rises secondary to the volume overload, okay, the heart is releasing natriuretic peptide. Okay, now this natriuretic peptide is released both at the levels of the atrium as well as at the level of the ventricle, but major amount of natriuretic peptide is released at the level of the atrium, and therefore they are also called as atrial natriuretic peptide. Okay, so once they are released, once this natriuretic peptide is released, what does it do? It is basically inhibiting the sodium absorption in the distal renal tubules, so excess amount of sodium excretion occurs along with diuresis. Okay, so this is how they are able to reduce the blood pressure. Okay, secondly, the heart can also cause excessive systemic vasodilatation, and ultimately it will cause decreased blood pressure. So at the level of the heart, whenever, remember, there is a fluid overload, the heart will automatically release atrial natriuretic peptide, which is going to cause loss of sodium ions in the urine and excessive diuresis. Along with that, they will also trigger systemic vasodilatation to ultimately bring down the blood pressure. So this is how the kidneys and the heart, they are regulating the blood pressure. Okay, so after this, now we are coming to the very important part, that is the pathogenesis of hypertension. So first we are going to discuss the pathogenesis of primary or essential hypertension, which is constituting 90 to 95% of all the cases. There is no identifiable cause of primary hypertension, so they are basically idiopathic in nature. Okay, so basically multiple genetic and environmental factors have been hypothesized to play an important role. So let us see. So what are the genetic factors? So genetic factors, they are definitely playing a role in hypertension, as it has been shown by comparisons between mono and dizygotic twins and between genetically related and adopted children. Now many JAVA studies, that is genome-wide association studies, points to more than 60 genetic loci in which the variants individually contribute minimally to blood pressure levels, but in total they have larger effect. So there are many small effects which is contributed by multiple genetic locus, and individually they are not having much change in the blood pressure. But when these changes, when these genetic changes, when small genetic changes, they come together along with other risk factors or predisposing factors, then they have a larger effect. As we know that hypertension is a multifactorial disorder. So this is the number one factor, that is the role of the genetic factors. Then insufficient renal sodium excretion. This is the most important cause of essential hypertension, or most important hypothesized reason of essential hypertension. So insufficient renal sodium excretion in presence of a normal arterial pressure may be the key initiating event in essential hypertension, and therefore a final common pathway for pathogenesis of hypertension. So very important, decreased renal excretion will cause increased fluid volume, okay, because once the sodium is retained in the body, therefore what is going to happen, water is also retained. So ultimately the amount of fluid in the body will rise. As a result, the cardiac output is going to increase, and to prevent hyperperfusion, the peripheral resistance also increases, thus entirely the BP increases. Okay, so insufficient renal sodium excretion has been hypothesized to be one of the major initiating causes of essential hypertension. Then there are certain vasoconstrictive influences. So certain factors, they induce vasoconstriction, or certain stimulus can lead to structural changes in the vessel wall, and ultimately they might lead to increased peripheral resistance, thus increasing the blood pressure. And certain environmental factors like stress, obesity, smoking, physical inactivity, heavy salt consumption. So all of these factors, okay, together they can cause essential hypertension. So remember, individually these factors are they have a very small effect, but together they have a very large effect in causing hypertension, essential hypertension. So this is about the essential hypertension. Now we are going to understand the mechanism of secondary hypertension. Now, for example, the first kind of secondary hypertension is the renovascular hypertension. So basically, in the renovascular variety, there is a renal artery stenosis, or there is a blockage in the renal artery, which is causing a decrease in the blood flow in the afferent arteriole. And as we have already seen, in any cause, whenever the blood flow in the afferent arteriole decreases, okay, that is going to stimulate the juxtaglomerular cells, releasing the amount of renin, releasing increased amount of renin, and therefore activating the RAS pathway, and that is going to lead to an increased amount of sodium retention and ultimately raised blood pressure. So renal artery stenosis is one of the identifiable secondary causes of hypertension. Now, any cause of primary hyperaldosteronism, okay, which might either be idiopathic or secondary to an aldosterone secreting adrenal tumor. So in any of these conditions, as we know, aldosterone is secondarily increasing the sodium reabsorption in the distal tubules and ultimately causing a rise in the blood pressure. Okay. Now, apart from that, there might be certain single gene disorders which can also, which are quite rare forms of hypertension, but when present, they are quite severe. So there are two types of single gene disorder. There are certain gene defects which is affecting the enzymes involved in aldosterone metabolism. So ultimately, because of defect in these enzymes, there is an excessive amount of aldosterone secretion which will cause salt and water retention, ultimately causing hypertension. Okay, and secondarily, there might be certain mutations affecting the proteins that influence sodium reabsorption. For example, Liddle syndrome. In Liddle syndrome, if you see, there is a mutation in the epithelial sodium channel protein that is increasing the distal tubular reabsorption of sodium in response to aldosterone. Okay, so these are some of the most important mechanisms of secondary hypertension. Now, clinically, it is very important for you to identify a condition, whether it is an essential hypertension or whether it is a secondary hypertension. So if it is a primary or essential hypertension, then nothing much can be done. But in case of secondary hypertension, if the cause is identified, then you can identify the cause and treat it, and therefore after treatment the pressure might return back to the normal level. Okay, so let us now see a very important example. Okay, a 55-year-old woman is visiting her physician for a routine health maintenance examination. On physical examination, her temperature is 36.8, pulse is 70, respiration is 14 per minute, and blood pressure is slightly raised to the tune of 160 by 105 millimeters mercury. Now, her lungs are clear on auscultation and her heart rate is regular. She feels fine and has no major medical illnesses or surgical procedures during her lifetime. An abdominal ultrasound scan shows that the left kidney is smaller than the right kidney. A renal angiogram shows a focal stenosis of the left renal artery. Which of the following lab finding is most likely to be present in this patient? Now, what is very important? This is a very important next based question. So over here we have to identify. So this is the question of primary or secondary hypertension. As you can see that a particular cause has been identified. So it is mainly a cause of secondary hypertension because of it is secondary to stenosis of the left renal artery, and whenever there will be stenosis, as we have seen, there will be a increase in the amount of plasma renin secondary to the reduction in the amount secondary to the reduction in the flow of blood to the afferent arteriole. Okay, so the levels of renin is going to increase. So the normal plasma renin level ranges from 0.5 to around 5 nanogram per ml per hour. That is the normal amount of renin which is released. So over here, if we are going to see some of these options like anti-dsDNA or C-ANC or cryoglobulinemia, so there are no signs symptoms of vasculitis, so these cannot be there. Again, the plasma level around 200 milligram per deciliter. So again, diabetes again does not have a direct predisposition over here. HIV test positive, as we have seen that the patient has not undergone any surgical procedure or any major illnesses she has not got. So serological test for different tests doesn't hold much value. But a plasma renin level of 15 nanogram per ml per hour, definitely there's a rise in the level of plasma renin. So most importantly, the basic idea with this question is that this is a case of secondary hypertension, and you have to identify the cause over here is focal stenosis in the left renal artery, and once that is there, it is going to raise the level of renin. So this will be the right option. Okay, option number F will be the right option. Now, a second very important MCQ over here is that a clinical study is performed that includes a group of subjects whose systolic blood pressure measurements are consistently between 145/95 to 165/105 millimeters mercury. Now, they are found to have an increased cardiac output and increased peripheral vascular resistance. Renal angiograms show no abnormal findings, and CT scan of the abdomen show no masses. Laboratory studies show normal levels of serum creatinine and urea nitrogen. The subjects do not take any medication. So what is very important that we have ruled out all the other causes. So no secondary causes were identified. So mainly this is going towards primary hypertension. Okay. So let us see over here which of the following laboratory findings is most likely to present in this group of subjects. So lack of ACE enzyme. Okay. No, this cannot be. If there is a lack of ACE enzyme, will not be associated over here, because basically there is no such thing over here. There is no renal artery stenosis, so this is not relevant over here. Decreased, because lack of ACE enzyme ultimately is going to cause a fall in the BP. So this cannot be. This is going to cause fall in the BP. So this will be a wrong option. Okay. So decreased urinary sodium. Yes, decreased urinary sodium can be the answer, because this decreased renal or urinary sodium basically is the initial step in the pathogenesis of primary hypertension, as we have already seen. So this might be the correct answer. Now, elevated plasma renin. Now, over here, if you see, elevated plasma renin levels basically occurs whenever there is a reduction in the flow. So as we can see, renal angiograms, they are completely normal. There is no stenosis, nothing. So again, elevated plasma renins cannot be. They are basically there in secondary causes. Okay. And basically over here, we can see that, there is no reduced, flow of blood. There is no reduction in the blood pressure. So the amount of flow to the kidney has to come down so as to elevate the plasma renin level. Okay. And basically plasma renin levels, they are raised mainly in secondary hypertension. Again, hypokalemia, primary aldosteronism, they can lead to hypokalemia. But over here, the CT abdomen, they do not show any mass. So no adrenal mass were seen over here again. Increased urinary catecholamines, again, they cannot be a cause, because pheochromocytoma again causes raised catecholamines. So again, that cannot be there. So there is no adrenal mass over here. So these cannot be the options. And this plasma renin levels cannot be raised. So the ultimate answer will be decreased urinary sodium. So ultimately, what do I want to tell you with this question is that this is a basic clinical scenario of a primary hypertension. And the most important cause or the initiating cause of essential hypertension is reduced urinary sodium, as we have already read about it. So these are two very important examples. One is of secondary hypertension, one is of primary hypertension. Now the next important MCQ over here is that a 60-year-old man presents with dizziness, nausea, severe shortness of breath of several months duration. So it is not an acute condition. Okay, it is a chronic condition. The physical examination is showing hepatomegaly ascites and anasarca. So there is edema, there is a generalized edema that is taking place. The blood pressure is around 200 to 115 millimeters mercury. An X-ray film of the chest is demonstrating cardiomegaly and mild pulmonary edema. Although different mechanisms may have contributed to the pathogenesis of hypertension in this patient, the common end result for all of them is which of the following? So let us try and understand and break this. Now, first of all, what is this condition? This is the condition of poorly controlled hypertension. And this has led to what is known as hypertensive heart disease. Hypertensive, there is a hypertensive heart disease which has taken place over here. Okay. So the patient is now gone into heart failure. Okay. As we can see from cardiomegaly and mild pulmonary edema. Okay. And also because there is the heart failure, there is hepatomegaly, ascites and anasarca. So generalized edema is there. Okay. And patient is also having signs, symptoms of, shortness of breath is there. So basically this is the case of a hypertensive heart disease that has taken place. So basically what is the common end result for all of them is what? So what is the end result? Now if you see over here, because the blood pressure is very high and there is a fluid overload. Okay, so there is a fluid overload that has occurred in the body, and whenever there is a fluid overload, there is an increased amount of cardiac output. So to protect the different kinds of tissues, okay, you have to increase the peripheral resistance as well, so as to contain that amount of fluid, so as to prevent any hyperperfusion of the different organs. So let us see the option. So the number one option is arterial cystic medial necrosis. Now this cannot be this is the seen in basically in the coarctation of the aorta. So this is not the option. This is the wrong option. Okay. Now the second important option over here is decreased plasma oncotic pressure. Now if for example if there is any kind of liver disease, okay, so there is a decreased production, or there is an increased renal disease with albuminuria. So that is going to cause a decreased plasma oncotic pressure. So over here clearly we can see that there is a cardiomegaly, there is a shortness of breath. Okay, so the cause of generalized edema, it is not decreased plasma oncotic pressure. Now generalized vasodilatation, no, generalized vasodilatation does not occur by itself. Now remember, generalized vasodilatation as well as increased vascular permeability, both of them, they can be a result of hypertension, but they by themselves, they cannot cause hypertension. So ultimately what is left over here, if you see, this cannot be, again this cannot be. So the ultimate answer will be increased peripheral vascular resistance. And we have already known over here that hypertension or the blood pressure, if you see, it is a direct product of cardiac output into peripheral resistance. Okay. So we have already seen over here. So ultimately the end result is increased peripheral resistance because of excessive fluid overload that has already taken place. So this is the diagnosis, is the hypertensive heart disease. Okay. Now let us see the vascular pathology in hypertension. So what happens to the blood vessels? So we are going to see the individual changes that is taking place. So hypertension accelerates the process of atherosclerosis, and not only that, they cause degenerative changes in the walls of the large and medium arteries, leading to aortic dissection and cerebrovascular accidents. Now, three forms of small vessel disease are hypertension related. So what are those? Let us see. The number one condition that we will discuss is hyaline arteriosclerosis. So what is it? So basically, arterioles show homogeneous pink hyaline thickening with associated luminal narrowing. Now it occurs because of plasma protein leakage across the injured endothelial cells, as well as because of increased amount of smooth muscle cell matrix synthesis, and both these things occurs in response to chronic hemodynamic pressures of hypertension. So because of the excessive or chronic hemodynamic pressure of hypertension, ultimately there is the plasma protein leakage across the injured endothelial cells, plus there is an excessive amount of smooth muscles matrix synthesis, and both these condition leads to the narrowing. It leads to the thickening of the blood vessel wall as well as luminal narrowing. Now very importantly, it is seen in vessels of older patients, that is this hyaline arteriosclerosis. This change is normally seen in elderly patients who can be normo or hypertensive. But the hyaline arteriosclerosis, it is quite severe in patients with long-standing diabetes mellitus and hypertension. So this Hyaline arteriosclerosis, it is not very, it is not something like it is specific for hypertension only. No, it is seen in diabetes as well as in hypertension, and it can be seen in older and elderly patients also. But very importantly, it is very much severe in diabetes and hypertensive patients. Now, in nephrosclerosis, which occurs in patients who are suffering from chronic hypertension, the arteriolar narrowing causes diffuse impairment of the renal blood supply, and ultimately the renal cortex will show scarring along with the shrinking. So, there is a renal cortical scarring along with shrinking, and this leads to a moderate reduction in the size of the kidneys. The kidney size becomes around 110 to 130 grams. And ultimately there is a tubular atrophy plus interstitial fibrosis, and in the end stages you will see glomerular sclerosis. So there is a complete renal scarring and reduction in the kidney size, and there is a bilateral reduction in the size of the kidney. So this is a very important. So long standing hypertension, okay, they cause moderate reduction in the kidney size owing to nephrosclerosis. Okay, now in nephrosclerosis, this is the continuation. The renal cortex, okay, grossly if you see, they will show fine even granularity, okay, that is grain leather granularity is seen, and this granularity is corresponding to microscopic subcapsular scars with sclerotic glomerulus and tubular dropouts alternating with better preserved parenchyma. Okay, so these are the two very important findings in nephrosclerosis. Grossly you will see fine even granularity, a grain leather granularity will be seen, and microscopically you can see glomerular sclerosis along with interstitial fibrosis and tubular atrophy. So this is the classical hyaline arteriosclerosis which we see in hypertension or in diabetic patients or also in normotensive elderly patients. But this is quite severe in diabetics and hypertensive patients. So what we can appreciate over here, if you see, what is this? If you see over here, this is basically a blood vessel, as we can appreciate over here. Okay, so this is basically a blood vessel, and if you look at the thickness of the blood vessel, they are having a increased thickness. Okay, they are having a increased thickness. Okay, so basically this increased thickness you can appreciate morphologically as a excessive eosinophilic deposition or excessive eosinophilic thickness can be seen, and this is called as a hyaline change. Now remember, hyaline change, it is just a descriptive term, okay, so as to describe this particular morphological appearance, and it has occurred because of excessive amount of plasma protein deposition across the damaged endothelial cells. So a lot of plasma proteins has deposited over here. Along with that, there is an excessive amount of smooth muscle cell matrix synthesis as well. Ultimately what has happened, that there is an excessive thickness of the blood vessel wall, as we can appreciate over here. See the thickness of the vessel wall, and because of this excessive thickness, if you look at the lumen, this is the lumen, so there is narrowing of the vessel lumen. Okay, so there is narrowing of the vessel lumen, as we can appreciate over here. So basically over here the arteriolar wall is basically thickened, okay, which is thickened because of excessive amount of protein deposition. That is why we are saying it is hyalinized. Hyalinized means it is a morphological appearance. Any amorphous pinkish appearance is called as a hyaline change, okay, and because of that there is a marked luminal narrowing. This is called as hyaline arteriosclerosis, and it is seen in elderly patients with normotensive or hypertensive blood pressure, and it is much more pronounced and much more severe in diabetic patients and hypertensive patients. So it is the classical finding seen in these patients. So let us look at this particular MCQ. A 60-year-old woman has reported increasing fatigue over the past year. Laboratory studies show a serum creat level of 4.7 mg per deciliter and urea nitrogen level of 44 mg per deciliter. An abdominal ultrasound scan shows that her kidneys are symmetrically smaller than normal kidneys. The high magnification microscopic appearance of the kidney is shown in the figure. So as you can appreciate over here, what is it? It is classically a case of hyaline arteriosclerosis. Hyaline arteriosclerosis, and because this is present over a period of a long period of time, So what has happened over here, that there is what is called as the diagnosis of this condition is actually, it is the condition of nephrosclerosis, okay? Because of chronic hypertension, there is a narrowing of the blood vessel supplying the kidney, leading to nephrosclerosis, and there is a cortical scarring and glomerulosclerosis has taken place, because of which the kidneys have become smaller because of destruction of the renal cortex, okay? So basically this is a classical case of systemic hypertension, which will be the answer, okay? So this is one important MCQ associated with hyaline arteriosclerosis, okay? Now this is another slide wherein we can appreciate the interstitial sclerosis that has taken place, the tubular sclerosis that we can appreciate over here, okay? The tubular sclerosis can be appreciated, okay? Glomerular sclerosis has also taken place, okay? So we have basically a special PAS staining has been done to highlight the areas of sclerosis. So this is a typical slide of nephrosclerosis because of chronic hypertension. So this is the first important vascular change that is seen in hypertension, that is hyaline arteriolosclerosis, okay? Now let us see the second important hypertension related vascular change. The second important thing is hyperplastic arteriosclerosis. It is occurring under the condition of severe hypertension wherein the systolic blood pressure is becoming more than 200. Okay, the vessels are exhibiting concentric laminated onion skin thickening of the walls with luminal narrowing. Laminations are basically consisting of smooth muscle cells with thickened reduplicated basement membrane. Now also we will appreciate over here fibrinoid necrosis of the vessel wall is also present over here. The classical condition wherein you see this hyperplastic variety of arteriosclerosis is malignant hypertension, wherein microscopically you are going to see the onion skin thickening of the vessel wall, and you are also going to appreciate fibrinoid necrosis of the vessel wall, okay? The third important vascular change that you will see is going to lead to pulmonary hypertension. Now it can occur because of many other causes also, like left-sided heart failure, congenital heart disease, valvular disorders, obstructive lung disease, interstitial lung disease, or recurrent thromboembolic disorders. Now over here the arterioles show fibrotic intimal thickening and as well as medial hyperplasia. So this is the very important last important change that we have seen. This is the condition wherein we can see hyperplastic arteriosclerosis. So what is it that we can appreciate over here? So you can see that there is a particular lesion. This is a blood vessel over here, okay? And in this blood vessel, around and around, just like an onion skin is there. So there's an onion skinning or onion skin thickening of the blood vessel with narrowing of the blood vessel lumen. Okay, this is the PAS stain wherein we are observing. And why is this onion skinning? Due to it is occurring because of the smooth muscle cells with thickened reduplicated basement membrane. So this onion skinning is nothing but the smooth muscle cells with reduplicated basement membrane, as we can appreciate over here. And this is the classical characteristic feature of hyperplastic arteriosclerosis, which is mainly seen in case of malignant hypertension. So let us see this MCQ. So for more than a decade, a 45-year-old man has a poorly controlled hypertension ranging from 150 by 90 millimeters mercury to 160 by 95 millimeter mercury. So already the patient is that of a hypertension, okay? Now already hypertensive patient, over the past 3 months, the blood pressure has increased to 250 by 125 millimeters mercury. On physical examination, his temperature is 36.9, his lungs are clear on auscultation, and his heart rate is regular. There is no abdominal pain on palpation. A chest radiograph is showing a prominent border on the left side of the heart. Laboratory studies shows that his serum creatinine level has increased during this time from 1.7 to 3.8. So there's a drastic increase. That means what we are seeing, that the patient is going into renal failure. What we can appreciate as the systolic blood pressure has become more than 200 millimeters per mercury, and it has taken place over a period of past 3 months, okay? And the patient was already a case, of hypertension. So taking all these parameters into the question, it is reflecting or it is fulfilling the criteria of malignant hypertension. So let me go back and show you the different criterias of malignant hypertension that we have read first. Okay, so let me just show you over here. So malignant hypertension, over here we had seen that the systolic blood pressure has become more than 200. So in this case it was 250. Then the diastolic was more than 120, it was 125. So this criteria was fulfilled. Not only that, the serum creatinine levels has also raised, so the patient had gone into renal failure as well. And not only that, we have also seen that this has developed, most commonly it develops in patients who are having pre-existing benign hypertension. So patient was already a known case of benign hypertension. So over here, as we have seen, this is the clear-cut case of malignant hypertension. So which of the following vascular lesion is most likely to be present? So it is a straightforward, as we have already seen over here, that malignant hypertension is characterized morphologically by the presence of hyperplastic arteriosclerosis characterized by onion skinning, as we can appreciate over here. So the option and the answer will be hyperplastic arteriosclerosis. So I hope you all have understood this topic in details. Thank you very much for watching this particular video.